I'm Dr. Fakir Abadi, and this is Opportunistic Infections in Adults. Opportunistic infections typically do not affect patients with an intact immune system, so the name opportunistic refers to the fact that these infections take advantage of immunocompromised patients. Immunocompromised patients not only can they get opportunistic infections, but they can also have non-opportunistic infections like other people. So infections like UTIs, community-acquired pneumonia, skin and soft tissue infections, etc. Which patients are considered immunocompromised? In general, advanced HIV, meaning a CD4 cell count of less than 200, as well as cancer patients receiving chemotherapy that cause myelosuppression, including neutropenia, and those patients who receive immunosuppressant therapy for either autoimmune conditions, as well as those who have received transplant, and that includes both solid organ transplant as well as stem cell transplant. And one thing that's very important to keep in mind is that use of systemic corticosteroids as a dose equivalent to prednisone, 20 milligram per day or more for at least 4 weeks is considered immunosuppression because that can affect the T cells. And asplenia. So the spleen has the function of filtering the blood. So specifically, any bacteria that's encapsulated will be removed by the spleen. So that includes pneumococcal species as well as Haemophilus influenzae. And asplenia could be either functional asplenia, for example, patients with sickle cell disease will have a non-functioning spleen, or if it's anatomical, meaning that it was surgically removed, so splenectomy. In this topic, we will focus on HIV-related opportunistic infections, which are those infections that are most frequent or more severe because of HIV-mediated immunosuppression. Now, in general, for patients who are linked to care and who manifest durable responses to long-term ART, survival of patients with HIV infection is currently almost equal to that of individuals without HIV infection. So, in general, these are basically becoming rare in patients with HIV because we have very effective ART. Now, one thing to keep in mind is that HIV-related opportunistic infections do not behave clinically exactly like opportunistic infections seen in other immunosuppressed population. For example, when we talk about toxoplasmosis in HIV, toxoplasmosis manifests mainly as encephalitis, whereas in patients with cancer or organ transplant, for example, it's more likely to be like visceral or disseminated disease. We're also going to talk about Pneumocystis Pneumonia, which is far more likely in patients with HIV. Yet the same organism often develops indolent disease in other immunosuppressed patients. So here's the problem in advanced HIV. So obviously a normal person has a large amount of CD4 cells. So here on the y-axis, we're looking at concentration of CD4 cell count in the blood. And on the x-axis, we're looking at time. So a normal person has very high number of cells, CD4 cells in the blood. And once this person gets a primary HIV infection, then these CD4 cells start to go down. And then as time goes on, and this is of course without ART, these CD4 cells start to go down in time. And then by the time it hits less than 350, this is where the risk of some infections go high, including some viral infection like varicella zoster, as well as other bacterial infections at tuberculosis. So these infections occur more frequently. Now these are not necessarily opportunistic, but the rate goes up. Now once you hit the the 200 mark. So if the CD4 is less than 200, that's when the risk of opportunistic infections becomes real. So this is when you get pneumocystis pneumonia, esophageal candidiasis, and then as the CD4 goes even lower, so less than 100, then the number of opportunistic infections go up. So you started to have more incidents of cocci, crypto, as well as toxoplasmosis and Mycobacterium avium complex. So for someone with CD4 cell count very low, specifically less than 200, the immune system is essentially non-existent. And now imagine an HIV patient who starts ART. So if the CD4 count is depleted and then they start ART, then CD4 can start to go up. Now this can result in a syndrome referred to as IRIS. So IRIS stands for immune reconstitution inflammatory syndrome, and this basically means that if you start ART and CD4 cell count goes up, then you start to have symptoms of inflammation. And that's because previously, because of the lack of immune, lack of an intact immune system, the patients are not capable of having that immune response, so symptoms of inflammation are non-existent. So when you start ART and these symptoms suddenly occur, which sometimes can be very severe, this can be due to two reasons. One is referred to as unmasking iris, which is basically, if someone already had an infection, but because there couldn't be an immune response to it, obviously there wouldn't be any symptoms. And once you start ART, then those symptoms basically become unmasked. So this is referred to as unmasking iris, that you just discovered an infection that was already in the patient. We just didn't know about it because of lack of symptoms. Another one is called paradoxical iris. And this is basically in someone who used to have an infection, but the infection is not necessarily there anymore. But the residual antigens from that previously resolved infection might be circulating in the body, and once you start ART and these CD4 cell counts go up, the body will have a response to it. So these are important to keep in mind in someone with CD4 less than 200. Once we start treatment of opportunistic infections, if you start ART at the same time, for some infection, initially it may look like the patient is getting worse, even though you just started ART. And that's typically not a concern because it's just iris happening. Now, I say typically there are situations where the iris can be severe, specifically when it comes to CNS infections. So, sometimes it might be necessary to actually treat iris with anti-inflammatory agents like corticosteroids. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for opportunistic infections. So trimsulfa, trimethoprim, sulfamethoxazole combination is by far the most commonly used agent. There are two brand names for it, Bactrim or Septra. And it's available as PO and IV. Most commonly it is used as PO. The IV formulation has very limited stability. So, if you can use PO is used more often. And the adverse profile, you can see that obviously these happen at the same time because trimsulfa is given often as a combination. Trimethoprim is also available as a standalone drug, but more commonly it's used in combination. So trimethoprim component can lead to anemia, leukopenia, thrombocytopenia, as well as hyperkalemia and hyponatremia. Trimethoprim can also inhibit the secretion of serum creatinine, so it can artificially increase serum creatinine levels without affecting GFR. So that's just an artificial. But the most important is really to keep an eye on the hyperkalemia when it comes to monitoring of trimethoprim. other adverse effects are not really as common for trimethoprim. For sulfamethoxazole, it's a sulfonamide, and for sulfonamide drugs in general, you want to think about skin reactions. So rash is the most common one, and sometimes it can be severe. So Steven-Johnson syndrome can happen. It's rare, but it can be fatal. And other skin-related reactions include photosensitivity. And in addition, sulfonamides can also have GI adverse effects, so nausea, vomiting, and diarrhea. And they can also be nephrotoxicity. So together, trimethoprim and sulfamethoxazole, really can cause nephrotoxicity, and this could be a combination of sulfonamide causing nephrotoxicity as well as trimethoprim artificially inhibiting the secretion of serum creatinine. You do need to renally adjust the dose of trimsulfa. So if creatine clearance is less than 30, half of the dose should be given. We also have sulfadiazine, which is also sulfonamide, so it's very similar to sulfamethoxazole. And we also have dapsone, which is similar to sulfonamides. Now, dapsone can cause methemoglobinemia and hemolysis, especially in patients with G6 phosphate, glucose 6 phosphate dehydrogenase deficiency. So it is recommended to test patients for glucose 6 phosphate dehydrogenase deficiency, and if they have that deficiency, it's best to avoid dapsone. Atovaquone inhibits ATP production by inhibiting the mitochondrial electron transport chain. It is very important to take this atovaquone with food in order to increase absorption. Now, we also have a couple of anti-malarial drugs that are used for opportunistic infections, so primaquine and pyrimethamine. And primaquine is actually contraindicated in patients with glucose 6-phosphate dehydrogenase deficiency, so it's absolutely essential to test patients for this deficiency before we start. And then leucovorin is basically a folic acid vitamin, which is used in combination with pyrimethamine in order to avoid the adverse effects, specifically hematologic adverse effects of this drug. So leucovorin technically is not an antibiotic. It doesn't do anything to opportunistic infections. It has to be given with pyrimethamine to basically avoid the severe adverse effects of that drug. And lastly, we have pentamidine, which is also available in an inhalation formulation, but it is not available as an oral formulation. Now let's take a look at some of the antiviral agents used for management of opportunistic infections. And here we're really talking about cytomegalovirus or CMV as the opportunistic viral infection. And because acyclovir, valacyclovir, and famciclovir are ineffective against CMV, we're not going to talk about them. The most common antiviral agent used for management of CMV is ganciclovir. And ganciclovir is basically a nucleotide analog, so it inhibits viral DNA synthesis. It has very poor oral bioavailability, so the oral formulation is no longer available in the US. It's primarily used as an intravenous injection. It can also be injected into the eye. Now, valganciclovir is basically a prodrug of ganciclovir, and this addition of valine group improves oral bioavailability. So it is available as PO, and it must be taken with food to increase absorption. And once it's absorbed, it's basically converted to ganciclovir. So mechanism of action is identical as well as the adverse effects. Unfortunately, these agents are very toxic. The most important toxicity of these agents is myelosuppression, and this is dose limiting. So patients basically will experience neutropenia and thrombocytopenia, so platelets will drop. Now, fortunately, this is reversible, so within 1 week of drug cessation, neutropenia should be resolved. There's also GI effects, so nausea and vomiting, as well as CNS effects, headache, insomnia, and it can be severe. So seizures and coma have also happened in patients, but is not as common. They can also cause hepatotoxicity. This is, mild elevation of liver enzymes. Is not as severe as CNS effects and myelosuppression. Some patients can experience fever, rash, anemia, and peripheral neuropathy. Now, cidofovir is also a nucleotide analog, and it's only available as IV because of poor oral bioavailability. Now, this agent is not causing as much myelosuppression as ganciclovir, but it is extremely nephrotoxic. In fact, it is the most nephrotoxic agent used for CMV. It is so nephrotoxic that initiation of cidofovir therapy is actually contraindicated in patients with existing renal insufficiency. And it must be administered with high doses of probenecid in order to block active tubular secretion and decrease nephrotoxicity. And before each infusion, cidofovir dosage must be adjusted for alteration in creatinine clearance or for the presence of urine protein, and aggressive adjunctive hydration is required. So normal saline would be administered before and after the infusion to reduce nephrotoxicity. Cidofovir can also cause anterior uveitis. So basically, this is inflammation in the uveal layers in the eye, and anterior means that this will be in the front of the eye as opposed to in the posterior area. Now let's take a look at foscarnet. So foscarnet is an inorganic pyrophosphate analog, so it is not a nucleotide analog, so the mechanism is very different. So when it comes to cross resistance, this becomes very important. But it does inhibit viral DNA synthesis, so the end product is the same. And it also has poor oral bioavailability, so it's only available as IV, and it can be also injected into the eye. It is also very nephrotoxic, so it's not as nephrotoxic as cidofovir, but it's very nephrotoxic, so it can cause a lot of electrolyte imbalances. So calcium can either go up or low. So, hyper or hypocalcemia can occur. It just depends. The same with phosphate. So, hyper or hypo, whereas magnesium and potassium will often be low. So, hypokalemia and hypomagnesemia. It can also cause GI effects, so nausea and vomiting, and some CNS effects, including seizures, some mild elevation of liver enzymes, as well as some, anemia, fatigue, rash, and leukopenia. But it's not, the leukopenia is not as severe as myelosuppression caused by ganciclovir and valganciclovir. Now, because of this severe nephrotoxicity of foscarnet, saline preloading is also recommended to prevent nephrotoxicity. So normal saline is often given before the infusion. Lastly, we have two new antiviral agents that are active against CMV, so letermovir and maribavir. These two agents are actually not used for treatment of CMV in people living with HIV. So letermovir is currently FDA approved for prophylaxis in recipients of hematopoietic stem cell transplant, and also FDA approved for prophylaxis in adults with kidney transplant. Maribavir is FDA approved for treatment of CMV in patients who are post-transplant with CMV that's refractory to the other antiviral agents. Now, in the future, they may get approved for treatment or prophylaxis of people living with HIV. So I have listed them here. Letermovir has a different mechanism of action. So it is a DNA terminase complex inhibitor. This is unique to the virus. It is needed for the processing and packaging of viral DNA. And because no mammalian cells have this DNA terminase, it has limited adverse effects when it comes to things like myelosuppression. So it is in general well tolerated. So it has safety advantage, but also because the mechanism of action is different, there is no cross resistance with the other antiviral agent. It is available as IV and PO, and it is well tolerated. Of course, you can have some GI effects like nausea, vomiting, as well as headache, fatigue, and tachycardia. With maribavir, it inhibits protein kinase UL97, which blocks nuclear egress of viral capsids, which I will explain in a moment what that means. And it is only available as PO. This one also has a different mechanism of action, so cross-reactivity is unlikely when it comes to resistance, and it is only available as PO, and it is well tolerated. Something unique about maribavir is that it can cause dysgeusia, which is essentially taste disturbance, but in general it's not cause for concern for patients discontinuing because of this, but this is something to provide education to patients. And this is similar to what people experience with Paxlovid, for example. You may have heard that some patients may have dysgeusia or dysgeusia. Now, maribavir blocks UL97 here, so UL97 is needed for the virus to have this process, and maribavir will block that. Now, keep in mind that UL97 is required for ganciclovir to work. So what you don't want to do is to use these two drugs in combination, because when you use maribavir will essentially prevent ganciclovir from being activated by UL97. So here's a comparison of mechanism of action of maribavir and letermovir. So once they go inside the cell, maribavir will block UL97, which is needed for phosphorylation of nucleotides that are needed for DNA synthesis. So that will interrupt DNA synthesis. Letermovir, on the other hand, once it goes into the cell, it will go inside the nucleus and inhibit terminase complex, which is needed for DNA replication. Now, there are some other agents listed here that are not available on the market, so I'm going to ignore them. Here are the black box warnings for cidofovir. So, of course, renal impairment, and there are recommendations from the FDA to reduce the possibility of nephrotoxicity. They also have neutropenia as a black box warning, as well as carcinogenic and teratogenic, and also hypospermia in men. Some of the contraindications include hypersensitivity, serum creatinine greater than 1.5, creatinine clearance less than 55, urine protein 100 or more, and use with or within 7 days of nephrotoxic agents. And these nephrotoxic agents include things like amphotericin B, aminoglycosides, NSAIDs, and also foscarnet. There are some situations where multiple antivirals can be used in combination when dealing with resistance. So there may be a situation where cidofovir and foscarnet might be needed to be used together, but that's actually contraindicated because of the nephrotoxicity. And of course, cidofovir should not be injected into the eye because of the toxicity to the eye. The next learning objective is explain the pathophysiology and clinical presentation of Pneumocystis Pneumonia, Toxoplasma, gondii Encephalitis, and Mycobacterium avium complex disease. Pneumocystis pneumonia, or PCP, is actually caused by Pneumocystis jirovecii, which is actually a fungus species. So PCP, which some people call PJP because of this change in nomenclature. So it used to be, PCP, the C used to stand for Carinii, but because it was, the taxonomy was changed, you may see the abbreviation PJP. But in general, the DHHH guidelines still refer to it as PCP. Now, because this is ubiquitous, it is thought that we all get exposed to this organism as during our childhood, and immunosuppressed the patient, it basically gets reactivated, and in HIV specifically, it can lead to the infection of the lungs and pneumonia. And 90% of PCP cases occur when the CD4 cell count is less than 200. So this is an important cutoff to remember. CD4, less than 200. Also, patients who do not have HIV, but they are on prolonged use of systemic corticosteroid, so typically at least 20 equivalent milligram of prednisone for at least 4 weeks. These patients will also be at risk of PCP because corticosteroids can also reduce the CD4 count. Now, transmission is person to person, so obviously healthy people can be colonized with this. It just doesn't cause an infection in an intact immune system. But immunodeficient people will actually develop the pneumonia. Now, when it comes to the host defenses, there is innate immunity, so alveolar macrophages as well as surfactant proteins protect individuals from this organism, as well as humoral immunity. So T cells, B cells, and immunoglobulins from the B cells are involved, which explains why patients with compromised T cell are at increased risk of getting PCP. So the clinical manifestations include exertional dyspnea as well as fever, non-productive cough, and chest discomfort, which worsens within days to weeks. Now, this is a progressive disease, so the prodromal period can extend from 3 to 8 weeks. So in general, for any infection, the initial phase is the incubation period, followed by prodromal period where you have mild signs and symptoms, and then you have a period of illness followed by a period of decline, as well as a period of convalescence. So in PCP, in HIV patients, this prodromal period could be very extended, 3 to 8 weeks. So it's very progressive. So for definitive diagnosis of PCP, histopathologic or cytopathologic demonstration of the organism is in either tissue, BAL fluid, or induced sputum sample is required. If you have chest radiograph, so technically basically chest x-ray, you will see symmetrical ground glass infiltrates. On chest CT, you will also see the same. The benefit of chest CT is that even if the chest x-ray is normal, you can still see the ground glass appearance on the chest CT. PCR is an alternative method. It's alternative because it's expensive, and it's also cannot distinguish between colonization and infection. And there's also the B-glucan test, which is highly sensitive but low specificity. So if it's positive, it doesn't necessarily mean PCP. It could be any fungal infection. But if it is negative, then you can rule out PCP. And lastly, one observation is that lactate dehydrogenase typically happens to be greater than 500 in patients with PCP, but that's non-specific. So, this is not really for diagnosis. It just gives you a clue if you see a high lactate dehydrogenase. Let's change gear to Toxoplasma gondii. So toxoplasmic encephalitis, or TE, is caused by Toxoplasma gondii. It is a protozoan parasite. So you can see that in the life cycle of this parasite, cats are involved as well as the livestock. So, the risk factors for getting this would be basically undercooked meat as well as raw shellfish, so oyster, clams, etc. As well as, if you have exposed vegetables, so untreated water or, organic food, or if you're growing your own food and cats are, or even livestock are around these, that could expose the patient to Toxoplasma gondii. Now, this is opportunistic infection, so people with an intact host immunity don't have to worry about this, but this is for people with CD4 count less than 200 that are at risk. So clinical manifestations include focal encephalitis with headache, confusion, or motor weakness and fever. For diagnosis, it is important for all patients with TE to be tested for Toxoplasma IgG because they will be seropositive. So Toxoplasma IgG will be positive. So if the IgG is negative, it's very unlikely that someone has toxoplasmosis. Now, definitive diagnosis requires 3 criteria. So a compatible clinical syndrome, so the symptoms have to be there, and then identification of 1 or more mass lesions by CT or MRI of the brain, as well as detection of the organism in a clinical sample, typically brain biopsy. And this is really reserved as a last resort. In other words, instead of doing brain biopsy, if someone has Toxoplasma IgG, you go ahead and treat them. It's really not necessary to go into brain biopsy. And lastly, Mycobacterium avium complex, or MAC. There are multiple species of Mycobacterium, so not Mycobacterium tuberculosis, but we'll talk about that on another day. But these are more of a slow-growing, non-tuberculous mycobacteria, which several of them that are common in these patients are grouped together and called a complex. So because avium is the most common one, gets the name. So Mycobacterium avium complex is a group of multiple mycobacteria. Regardless, these are opportunistic infections that typically occur in people with HIV with CD4 of less than 50. So this one, you really have to deplete the CD4 cell counts in order to be exposed to this. We will discuss more about mycobacteria in general when we talk about tuberculosis on another topic. Symptoms include fever, night sweats, weight loss, fatigue, diarrhea, and abdominal pain. So you will see that these symptoms are also common in tuberculosis, night sweats, weight loss, as well as anemia and elevated liver alkaline phos. For diagnosis, a confirmed diagnosis is based on compatible clinical signs and symptoms, as well as isolation of MAC from culture of blood, lymph node, bone marrow, or other normally sterile tissue or body fluids. Now, cytomegalovirus is widely prevalent herpes virus. It is a double-stranded DNA, and the primary route of transmission is by interpersonal contact via infectious body fluids, including saliva, semen, cervical secretions, as well as breast milk. Now, when somebody gets infected by CMV, it establishes latent infection in the host after recovery, just like all other herpes viruses. And pretty much more than half of the population is infected with CMV. Fortunately, there is no disease in healthy hosts, so it's pretty much asymptomatic infection in healthy individuals. Now, it does cause congenital CMV syndrome in neonates, which could be fatal for neonates. And it can cause infectious mononucleosis in young adults, essentially manifesting as fever, malaise, and myalgias. Now, the real problem is when we go from CMV infection to CMV disease. So severe disease syndrome occurs in immunocompromised individuals, and that includes recipients of solid organ transplants. So solid organ includes the lung, liver, kidney, and heart, as well as recipients of hematopoietic stem cell transplant, and patients with HIV and advanced immunosuppression. Specifically, a CD4 count of less than 50 puts these individuals at risk of severe disease of CMV. Now, what exactly is CMV disease? So CMV can cause retinitis in the eyes. It can cause colitis in the GI tract, esophagitis also in the GI tract, and pneumonitis and neurologic disease. The most common in individuals with HIV is retinitis. And this really up to 30% in individuals not receiving ART. In the era when individuals are receiving ART, it's really not as common anymore. And it's followed by colitis, about 5 to 10% of individuals. And then esophagitis in a very small percentage. Pneumonitis is very uncommon. Now let's take a look at some of the symptoms. With rhinitis, basically patients will experience floaters, which essentially means spots in the vision. Scotoma, and the plural for scotoma is scotomata, and it essentially means a partial loss of vision or blind spot in an otherwise normal visual field, and of course peripheral visual field defects. And diagnosis is done by an ophthalmologist through eye examination. Patients with CMV colitis experience weight loss, fever, anorexia, abdominal pain, diarrhea, and malaise. And it can be severe if it causes hemorrhage and perforation, which can be life-threatening in patients. We describe the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for opportunistic infections, and we explain the pathophysiology and clinical presentations of Pneumocystis Pneumonia, Toxoplasma gondii encephalitis, Mycobacterium avium complex, and Cytomegalovirus disease. Now, given a patient living with HIV, let's assess the need for opportunistic infection primary prophylaxis. Let's take a look at PCP primary prophylaxis. Primary prophylaxis means that we are preventing PCP for the very first time. So these patients living with HIV have not had PCP previously. So the indication is that any patient with CD4 count between 100 to 200 and a detectable HIV RNA should be receiving PCP prophylaxis. And regardless of HIV RNA in the plasma, if the CD4 count is less than 100, all patients who meet this criteria should be receiving PCP prophylaxis. The preferred agent for PCP prophylaxis for patients living with HIV is Bactrim. So either a double string or a single string tablet orally daily. Now, of note, patients who also need to be on prophylaxis for toxoplasmosis, Bactrim 1 double string daily is also preferred for prevention of toxoplasmosis, which we will discuss shortly. Speaking of toxoplasmosis, when we choose alternative agents for PCP prophylaxis, we need to consider whether they cover toxoplasmosis or not, because if the patient also needs toxoplasmosis prophylaxis, we need to choose an agent that also covers that. So alternative agents for PCP prophylaxis that also covers toxoplasmosis include alternative dosing of trimsulfa, so essentially 3 times weekly, dapsone in combination with pyrimethamine and leucovorin, that are, the dapsone part is daily and pyrimethamine part is weekly. Dapsone, pyrimethamine, leucovorin, the entire thing weekly, or atovaquone suspension given daily with food. So these are alternative, and they also cover toxoplasmosis in case the patients need it. Now, other alternatives that do not cover toxoplasmosis include dapsone monotherapy. So this is given either once a day or twice a day daily, and pentamidine, either aerosolized, specifically via Respigard 2 nebulizer every month, or given every 28 days as an intravenous injection. So these 3 regimens do not cover toxoplasmosis, so it's important to consider that in case the patient also needs coverage for toxoplasmosis, they need additional agents. Now, primary prophylaxis should be continuous until the patient's CD4 count goes over 200 for at least 3 months as a result of initiation of ART. Or if the patient's CD4 goes between 100 and 200 and the HIV RNA level is undetectable for at least 3 to 6 months. Now, we have a lot of options on this page. So let's take a look at Bactrim, for example. So we have double string daily, single string daily, and then less frequent dosing. So in general, it's best to use the highest tolerable dose to maximize the efficacy. So if the patient cannot tolerate double strength, single string can be used, and if that cannot be tolerated due to adverse effects, then we can use less frequent use of trimsulfa or other agents. In general, things like fever and rash are less likely with lower doses of Bactrim, Whereas, if the patient has more severe adverse effects, such as Stevens-Johnson syndrome, then Bactrim actually should be discontinued and not reintroduced, so other agents should be used for such patients. These alternative agents are also listed in order of preference. For example, atovaquone is listed last. Atovaquone has unpredictable bioavailability, it's expensive, and it has a bad taste. Of note, pyrimethamine is also extremely expensive and currently is very difficult to obtain in the US. Now let's take a look at Toxoplasma gondii encephalitis primary prophylaxis. So all the recommended regimens for preventing first episode of toxoplasmosis are also effective in preventing PCP, except pyrimethamine and leucovorin without dapsone. Now, aerosolized pentamidine does not protect against toxoplasma, so it is not recommended for prophylaxis. Neither does dapsone monotherapy, so dapsone alone should not be used for toxoplasmosis. Now, who should receive primary prophylaxis? Essentially, patients with a positive IgG for toxoplasma with CD4 count of less than 100 should receive prophylaxis. So patients who do not have IgG positive, it's extremely unlikely for them to develop toxoplasmosis. So that's why that's a requirement here. So if somebody's CD4 is less than 100 but their IgG is negative, they don't necessarily qualify for primary prophylaxis. The preferred regimen for primary prophylaxis of toxoplasmosis is a double strength Bactrim, so trimsulfa, 1 double string daily. And then the alternatives include lower doses of Bactrim, so either double strength 3 times a week or a single strength daily. Dapsone in combination of pyrimethamine and leucovorin, and either in daily or weekly form. Atovaquone is an alternative, and also as a last resort, pyrimethamine plus leucovorin. So essentially this doesn't have dapsone. This is a last line because essentially anybody who qualifies for primary prophylaxis of toxoplasma also needs to be on prophylaxis for PCP, and because this doesn't cover PCP, this is last line, so anybody who is taking this essentially needs to be on another agent to give coverage for PCP prophylaxis. And prophylaxis should continue until the CD4 count is over 200 for at least 3 months as a result of ART initiation, or if the CD4 is between 100 and 200, HIV viral load should also be undetectable for 3 to 6 months, and then the patient can discontinue toxoplasma prophylaxis. Now let's take a look at disseminated Mycobacterium avium complex, or MAC. So primary prophylaxis against disseminated MAC is not recommended if the patient is receiving ART. So that's a very important thing to consider. That's regardless of what the CD4 count is. If somebody is on ART, they do not need to be on it. So to qualify, they essentially should have detectable viral load or not be on ART, and their CD4 count less than 50. Then they qualify for prophylaxis. And macrolides are the preferred agents for MAC prophylaxis. So it's in the name. Macrolides for MAC prophylaxis. So azithromycin 1200 milligram once weekly is the most commonly used. It's convenient once weekly. Clarithromycin 500 milligram POBID is also preferred. And of course azithromycin 600 milligram twice weekly. Alternatively, rifabutin daily is an option for people who cannot tolerate macrolides. However, for this to be used, we should rule out active tuberculosis in order to avoid the resistance in TB to rifabutin. And prophylaxis should continue until the patient is initiated on ART. For prevention of CMV end organ disease is best prevented using ART to maintain the CD4 count over 100. So using viral agents like valganciclovir for primary prophylaxis is not recommended, even in patients who have CMV viremia. Now, since these patients could have CMV viremia and not receive valganciclovir, it is important to monitor for development of floaters or changes in visual acuity, because CMV can affect the eyes, and refer the patients to ophthalmology. And ophthalmologic examinations every 3 to 4 months for patients with CD4 count less than 50 is recommended. We described the pharmacokinetic and pharmacodynamic properties of anti-infective agents used for opportunistic infections. We explained the pathophysiology and clinical presentations of common opportunistic infections. And we looked at patients living with HIV to assess the need for opportunistic infection primary prophylaxis. Now, given a patient living with HIV who is infected with an opportunistic infection, let's recommend guideline-concordant treatment. A fundamental part of treatment of opportunistic infection is initiation of ART if the patients are not already on it. For PCP, it is important for patients to be started on ART, if possible, within 2 weeks of diagnosis of PCP. Now, it's important to note that aerosolized pentamidine should not be used for treatment of PCP because it has limited efficacy and it is associated with more frequent relapses. And whenever possible, patients should be tested for glucose 6-phosphate dehydrogenase deficiency before primaquine or dapsone is administered. Treatment of PCP is based on severity of infection. So mild to moderate severity, which can be treated with oral treatments, they do not require IV administration of drugs, is defined as either PaO2 of at least 70 millimeter of mercury at room air. PaO2 is partial pressure of arterial oxygen, or PaO2 gradient less than 35 millimeter of mercury, and so the capital A is for alveolar oxygen, whereas the lower A is for arterial. The preferred treatment for PCP, mild to moderate PCP, is Bactrim. So either dosing by body weight, so 15 to 20 milligram per kilogram per day, so that's a total daily dose that should be divided in 3 doses, which translates into roughly 5 to 7 milligram per kilo per dose, or a fixed dose of 2 double strength tablets 3 times a day. So those are preferred. And alternative agents for people who cannot tolerate Bactrim is dapsone plus trimethoprim component, or primaquine plus clindamycin combination, or atovaquone suspension. Now, atovaquone is less effective compared to the other agents listed here, and treatment should be for 21 days. For moderate to severe infection, patients must receive IV treatments initially if they can, and the definition is PaO2 of less than 70 on room air, or a gradient of greater than 35 millimeter mercury. And the treatment again is trimsulfa at 15 to 20 milligram per kilogram per day, divided into 3 to 4 doses, and this should be administered IV. And patients may switch to PO after clinical improvement. And again, treatment is for 21 days. Patients who cannot tolerate trimsulfa, alternative regimens for them includes primaquine, which is actually only available as PO, so we may have no choice but to give them primaquine PO, but the clindamycin part can be IV. Or if oral option is not, the patient cannot orally absorb medications, pentamidine IV is available as an alternative. And very important for patients with moderate to severe is the adjunctive treatment of prednisone. This is associated with reduced mortality. So these patients who have moderate to severe PCP are at increased risk of dying. So prednisone, which can be given over the 21 days as a taper. So the first 5 days would be 40 milligram twice a day, and then the next 5 days is 40 milligram once a day, and then the final days of day 11 through 21 is 20 milligram daily. Now, if the patient cannot take orally, we can use IV methylprednisolone that can be given as 80% of the prednisone dose, so we can adjust from there. Secondary prophylaxis for PCP should be started immediately upon completion of the 21 days of treatment, and should continue until the CD4 count is more than 200 for at least 3 months. Or if the CD4 is between 100 and 200, the RNA must be undetectable for at least 3 to 6 months. Now, for secondary prophylaxis, again, the preferred agent is trimsulfa, either double strength or single strength. Alternatives include lower doses of trimsulfa, dapsone, pyrimethamine, leucovorin, atovaquone, and of course there are alternatives that do not cover toxoplasmosis in case the patient need toxoplasmosis coverage. That's important to consider. Let's take a look at treatment of Toxoplasma encephalitis. So preferred agent is pyrimethamine sulfadiazine plus leucovorin, and also we have, this is new in this guidelines, trimsulfa is also considered first line. There is significantly more evidence with pyrimethamine and sulfadiazine. That's why that's listed first, but trimsulfa is also has made it to be preferred. Alternative agents include pyrimethamine and clindamycin, or some combinations of atovaquone with pyrimethamine or sulfadiazine, or atovaquone monotherapy. Treatment should be for at least 6 weeks, and of course longer duration if clinical or radiologic disease is extensive or response is incomplete at 6 weeks. And again, upon completion of treatment, secondary prophylaxis should initiate. In this case, for Toxoplasma, we call it chronic maintenance therapy, which essentially the agents are similar. So preferred is pyrimethamine, sulfadiazine plus leucovorin, or trimsulfa, and we have some alternative regimens. Now, chronic maintenance should continue until the patient is asymptomatic and CD4 count is more than 200 for at least 6 months. For treatment of disseminated MAC, of course, ART should be started as soon as possible after diagnosing MAC, preferably at the same time as initiating the anti-mycobacterial therapy. At least 2 drugs should be used in combination when treating mycobacterial infections. And we should test for susceptibility to clarithromycin and azithromycin. So here are the recommendations. So again, macrolides are preferred agents for MAC, including for treatment, but in combination with ethambutol. So clarithromycin has the most evidence with it. So even though it has significant drug interactions and strong QTc prolongation, clarithromycin, if the patients can tolerate it, should be started BID. Along with ethambutol. Alternatively, azithromycin in addition to ethambutol can be considered preferred. Alternatively, a third or a fourth agent can be added to this combination of macrolide and ethambutol. Many patients, especially if the patient has more severe infections, as well as if there is a high mycobacterial loads, or if the patient is not on ART, rifabutin can be added to that backbone of macrolide and ethambutol. We also have specifically a couple of fluoroquinolones, so levofloxacin and moxifloxacin can be added to that backbone. And as a last resort, injectable aminoglycosides, specifically amikacin and streptomycin, can be added to that backbone, not other aminoglycosides. And then based on in vitro activity, if someone has refractory MAC disease, essentially bedaquiline, tedizolid, linezolid, and omadacycline could be considered. Treatment is for at least 12 months, and then patients transition to chronic maintenance therapy or secondary prophylaxis, and that should continue until the patient is asymptomatic and has completed 12 months of treatment and CD4 count is over 100 for at least 6 months. Because retinitis is the most common CMV disease, we will focus on managing CMV retinitis. The choice of therapy should be individualized based on tolerance of systemic medications, prior exposure to anti-CMV drugs, as well as on location of lesions in the eye. For example, someone who has been receiving valganciclovir, they may have developed resistance to cyclovir and valganciclovir, so they may need cidofovir or foscarnet. Now, systemic therapy, either IV or PO, systemic as opposed to intravitreous injection, has been shown to reduce CMV involvement of the contralateral eye, to reduce CMV visceral disease, as well as to improve survival. So the first line therapy includes either IV ganciclovir or PO ganciclovir. Many clinicians prefer the IV formulation when retinitis is more central and site threatening, or when adequate GI absorption is a concern, so PO cannot be an option. On the other hand, for patients without sight-threatening lesions, oral valganciclovir alone often is adequate. Now, initially, there will be induction therapy, which would last for a minimum of 14 to 21 days, and there is a range, and that will be determined by clinical response based on ophthalmologic examination. And then this will be followed by a maintenance therapy. So during induction therapy, we give a higher doses of these, either ganciclovir or valganciclovir. So there will be higher doses during induction therapy. And then for maintenance therapy, there will be lower doses. And obviously, the primary concern with the high dose during induction therapy would be myelosuppression caused by these agents. And then the maintenance therapy will continue for 3 to 6 months until these patients, while they're taking their ART, they should be able to achieve a CD4 count of at least 100 for 3 to 6 months. And once the lesions are inactive, then maintenance therapy can be discontinued. On the other hand, if the patient's CD4 goes below 100, once somebody has developed CMV retinitis after completion of therapy, if their CD4 goes to less than 100, then chronic maintenance therapy should be reinstituted. Now, alternative therapies include IV foscarnet or IV cidofovir. It's very rare to use IV cidofovir because of the complications of dosing and managing nephrotoxicity. For patients that toxicity of ganciclovir or valganciclovir of myelosuppression is a concern, and if those patients do not have renal insufficiency, or if somebody has ganciclovir resistant CMV, for those patients, IV foscarnet may be used. Now, for patients who have sight-threatening lesions, in addition to systemic therapy, it's recommended to also add, in addition, adjunctive intravitreous weekly injections of either ganciclovir or foscarnet in order to achieve enough of the drug, adequate concentrations of the drug in the eyes. So these are the possibilities. So the preferred therapy includes either IV ganciclovir high dose twice a day, for the induction therapy of 14 to 21 days, and then switching to a lower, once a day dosing of IV ganciclovir for maintenance therapy. Alternatively, we can do just the induction therapy of IV ganciclovir and then switching to oral valganciclovir for the maintenance therapy, or for mild cases without sight-threatening lesions, the entire regimen could be oral. So twice a day dosing of oral valganciclovir for induction therapy, and then switching to once a day dosing for maintenance therapy. And at any time, regardless of which regimen is used, IV ganciclovir can be switched to oral valganciclovir as long as the patient is clinically improving and there are no concerns about GI absorption. For example, if somebody also have CMV colitis. Now, alternative therapies are listed here, foscarnet and cidofovir. You can see that, cidofovir is very, very difficult, so it's, very rarely used. It's hard to find, people who would need cidofovir, because in cases of resistance, foscarnet would be an option. Now, treatment of other complications of CMV, such as colitis, are similar to retinitis. Obviously, there will be no intravitreous injection for other CMV diseases. This concludes this presentation.